Welcome back to the Great Adventure, Pediatric Pulmonary Physiology. This is the 10th presentation in our series, and it's Pulmonary Function Testing Part 2, and today we're going to talk about lung volumes. So this is the Great Adventure, Pediatric Pulmonary Physiology, and as mentioned, it's the 10th in the series, and we want to, again, approach this like a kid in a candy shop. Abnormal pulmonary function parameters, there are only two: restrictive lung diseases, which are stiff lungs, decreased lung volumes, and obstructive lung diseases characterized by airway obstruction. So today we're going to talk about lung volumes. So we're going to talk about total lung capacity and vital capacity, residual volume, my favorite lung volume, and how to measure FRC, or functional residual capacity. So we'll go over nitrogen washout, helium dilution, and body pressure plethysmography. So first, total lung capacity and vital capacity. So restrictive lung disease is defined as decreased compliance or stiff lungs and small lung volumes. They're difficult to inflate, as shown here, and there's increased work of breathing. So these are the lung volumes. If we have a spirogram here, somebody breathing along normally, taking deep breath all the way in, blowing it all the way out, and it gives us these four lung volumes: inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volume, and then four capacities, which are a sum of two or more lung volumes. So vital capacity, inspiratory capacity, total lung capacity, functional residual capacity. Here, for your review, is listed the full names of these volumes, and frankly, a pulmonary fellow or pediatric pulmonologist just needs to memorize these. It's that simple. We're going to talk about the most important ones. So functional residual capacity is shown here. Functional residual capacity is the volume of air in the lungs, total volume of air in the lungs at the end of a normal exhalation. So you're sitting here, you're breathing in, breathing out. The amount of air in your lungs at the end of a normal exhalation is functional residual capacity, or FRC. It's the most stable lung volume. And the reason is it's determined physiologically. So if I were to slit my sternum down the middle, okay, my lungs would collapse inwards because of the elastic tissue in the lungs, decreasing lung volume. My chest wall would actually recoil outward, which would increase lung volume. So FRC is the equilibrium between outward chest wall recoil and inward lung recoil. And the important thing about FRC is this is where you live. This is the volume in your lungs in a normal sort of situation. Total lung capacity. Total lung capacity is the total amount of air in your lungs after maximal inhalation. And this is the measure of lung size. So a decrease in total lung capacity can be due to parenchymal disease, stiff lungs, decreased lung compliance, decreased ventilatory muscle strength, if I don't have strong enough muscles to inspire fully, or decreased or extrinsic compression from chest wall anomalies, the most common being scoliosis. A decrease in total lung capacity is the definition of restrictive disease. So here we have a normal situation, normal spirogram, if you will, normal total lung capacity, and this would be an example of someone with restrictive disease. The total lung volume here, capacity, is decreased. We grade these, and admittedly this is somewhat arbitrary, but at Children's Hospital Los Angeles, these are the gradations that we use for severity of restrictive disease. So above 77% predicted TLC is normal. There's no restriction. 70 to 76 is mild restrictive disease. 60 to 69 is moderate, and less than 60 is severe restrictive disease. Vital capacity. Vital capacity is the volume exhaled from total lung capacity. That's from all the way in to all the way out. So you're taking in a full breath all the way in and blowing it all the way out. That is the vital capacity. In a sense, it's a usable lung volume. Now, a decreased vital capacity is due to the same three things that decrease total lung capacity: parenchymal lung disease, that is stiff lungs, decreased compliance; decreased ventilatory muscle strength; extrinsic compression from chest wall anomalies, the most common being scoliosis; and hyperinflation. We talked about this a little bit in mechanics. We'll revisit it. This can increase the residual volume, which will decrease vital capacity. To detect restrictive disease, if we look at a normal situation here, the blue is vital capacity. Restrictive disease is going to be decreased, as is total lung capacity. But airway obstruction can have hyperinflation so that this residual volume is high and the vital capacity is low, even though the total lung capacity is normal. So that's why if you're measuring full lung volumes, vital capacity is not adequate to define restrictive disease. You really need to have a measure of total lung capacity. Let's talk about residual volume. You cannot exhale to completely empty your lungs. Why not? If you take a breath all the way out and push as hard and fast as you can, you have not degassed your lungs. You still have air in there. What prevents you from exhaling? So this is the residual volume. It's the volume left in the lung after a maximal exhalation. And the good thing is that this prevents a right to left shunt during exhalation. So even if you exhale maximally, blood goes through pulmonary capillaries, which pass an air interface so that gas exchange can still occur. The inability to exhale further at residual volume is due to only two things: airway closure or the inability to compress outward chest wall recoil any further. An increase in residual volume that is excessive or abnormal is hyperinflation, and it's commonly seen in airway obstruction, though not only in airway obstruction. We talked about intrapulmonary airway obstruction. Remember, intrapulmonary airway obstruction is not an inspiratory problem because you have elastic recoil, elastic tissue that's opening up airways. But during exhalation, you have positive pressure on the airways so that pressure inside the airways at points can be less than outside, causing compression or obstruction. So intrapulmonary airway obstruction is an expiratory phenomenon. So as you exhale, airways get smaller. Right, there's less elastic recoil and their caliber is decreased. This again is a micrograph of the airways, and it simply shows you that these airways are, in a sense, distended by the elastic tissue and alveolar walls that kind of radiate outwards like spokes. So for airway obstruction, remember that airways are bigger during inhalation than exhalation. So the obstruction will be worse, and you can have some situations where the where airway obstruction allows air through on inhalation but not on exhalation. That will cause hyperinflation or cause this structure to become enlarged. So airway closure cannot be overcome by increased effort. We talked about that when we talked about mechanics. Airway closure causes an inability to exhale further. So an increased residual volume is hyperinflation, and it's commonly seen in airway obstruction. The chest wall tends to recoil outward at FRC. So as one exhales to residual volume, outward recoil of the chest increases, and it becomes more difficult to compress the chest any further. So the inability to compress the chest wall further is another determinant of the residual volume. Inability to compress the chest wall early in exhalation increases residual volume and causes hyperinflation. This will be present in chest wall disorders such as scoliosis and in expiratory muscle weakness such as in neuromuscular diseases. So in scoliosis, all right, here's a straight spine, here's a scoliosis spine. You have both concave and convex lung in scoliosis. Think about how this can be compressed. It can't really be compressed easily because that rib cage is kind of spewed or splayed outward. So this is going to increase residual volume. And in scoliosis, an increase in residual volume due to inability to compress this convex lung often occurs as scoliosis gets more severe before a decrease in total lung capacity occurs. If you have obstructive lung diseases, the mechanism determining your residual volume is airway closure. If you have chest wall anomalies or neuromuscular disease, the mechanism determining your residual volume is the inability to compress chest wall recoil any further. So again, inhalation to exhalation, airways are becoming smaller. So Tony Mansell uh, did a study where he looked at closing volume. We'll talk about this later, but just for the moment, it's a volume at which airways begin to close. High is bad, all right, and plotted against the elastic recoil of the lung at 90% total lung capacity, all right. And what he found was that the closing volume basically varied inversely as elastic recoil. That is, those lungs that had little elastic recoil had a higher airway closure. Airways were closing, they weren't supported. Those that had more elastic recoil had less airway closure. Right? This is a plot of normal static elastic recoil by age. And you can see that for children, elastic recoil increases because you're increasing alveolar number. And remember, alveolar walls contain elastic tissue. And then, probably after about late adolescence, early 20s, your lung function starts to decline. That is, your maximal static elastic recoil decreases with age. So I'm not even on this curve. That's somewhat disappointing. But as one ages, you lose alveoli and therefore lose elastic recoil. So this is the normal curve of elastic recoil versus age. This is the normal curve of closing volume by age, and you can see it's the reciprocal. Okay, so closing volume is high when elastic recoil was low. Closing volume is lowest, meaning best, when elastic recoil was the highest. And then as one ages, elastic recoil decreases and closing volume increases. So airway closure occurs when elastic recoil is lowest. Thus, airway closure determines the residual volume as one ages, if we're talking about what determines the residual volume in normal subjects. Chest wall recoil determines the residual volume when airway closure is less likely to occur. If we go back to this graph, the residual volume is primarily determined by elastic recoil or inability to compress your chest wall any further up through early, mid, maybe late 20s. After that, residual volume is determined by airway closure. If you're in an adult laboratory, okay, you would have been taught that all lung volumes in restrictive disease, all lung volumes decrease proportionally. So if you have a total lung capacity of 60% predicted, your residual volume is also going to be 60% predicted. That means that the residual volume decreases in proportion to the total lung capacity. The RV-TLC ratio is preserved, and the residual volume is determined by airway closure. Increased recoil, okay, as in this situation, would keep airways open. So if you had interstitial lung disease, for example, you might have increased recoil, and you could actually potentially get supernormal flows. Children, however, are different. So if this is normal, this is restrictive. In a child, normal child, remember that residual volume is determined by inability to compress the chest wall any further. Okay? So even if you've got small lungs inside that chest, the normal mechanism, that is compressing your chest wall, um, remains. And so the residual volume is relatively normal, even though the other volumes are decreased. So this is a major difference. Residual volume is normally determined by outward chest wall recoil. Even if the lungs are small, one cannot compress the chest wall any further. Therefore, the residual volume is not decreased, and it is determined by the normal mechanism. The RV-TLC ratio is increased because of a decreased total lung capacity, not because of increased residual volume, so there is no hyperinflation. To assess hyperinflation in children, we recommend the following. First, you look at the absolute value of residual volume. If it's normal, there's no hyperinflation. If it's increased, next assess the RV-TLC ratio. If it's normal, the increased residual volume is due to big lungs and is not hyperinflation. If it is also increased, then there's hyperinflation. So the absolute value of the residual volume must be increased and the RV-TLC ratio must be increased. And this is shown here. So here, in restrictive disease in children, you can see this residual volume is not decreased very much, but the ratio is going to be. In obstructive disease, you might have a large TLC, or even if it's normal, the residual volume is large, and this would be hyperinflation. In terms of severity, again, somewhat arbitrarily, Children's Hospital Los Angeles, these are the values we use. A residual volume up to 123% predicted is normal. 124% predicted to 199 is mild. 200 to 299 is moderate, and greater than 300% predicted is severe. These numbers, I realize this seems pretty large, but it's based on the fact that we see a fair range in actual residual volumes, so that severe, in our experience, would be greater than 300% predicted or greater than 3 times normal. One interesting aspect of pediatric pulmonary physiology is that the same etiology can present as different diseases based on the stage of lung development. A classic example is that RSV, respiratory syncytial virus, causes a mild upper respiratory infection in adults, but potentially a life-threatening bronchiolitis in infants. Early lung disease may also alter subsequent lung development, leading to long-term sequelae. Right, this was a study by Meyer Catan, and he looked at asymptomatic adolescents who had had bronchiolitis during infancy. And these all had normal FEV1, FEV1 over FVC, and normal FEF25-75. But you can see that 70% still had hypoxia, 57% had an abnormal volume of isoflow, which we will discuss down the road, 30% had hyperinflation. And again, flow is corrected for lung volume here. This is the same test here, and you can see that these individuals were above the normal range for RV over TLC. So RV is a sensitive test. This is a test of CF, cystic fibrosis patients with mild disease. Again, hypoxia the most sensitive, but again, the hyperinflation was second and more sensitive than standard spirometric values. This is a different study looking at, again, cystic fibrosis patients with mild disease. In this case, elevated residual volume was even more sensitive than oxygenation. And this study looked at asthmatic children, again, who were not having an episode. And again, residual volume was more sensitive than standard spirometry. And finally, this is asthmatics again in the different study with the percent who were hyperinflated were more common than those with either total lung capacity, residual volume, or measures of oxygenation. This particular study showed that survivors of severe BPD had an increased residual volume as adults. David Botter, who was a pulmonary fellow here, Children's Hospital Los Angeles, 85 to 87, did a study looking at children age 10 who had had BPD as infants. And you can see that their estimated gestational age by design was different, as was birth date, and days on assisted ventilation or oxygen. Obviously, the controls did not have that. He showed total lung capacity was not different between these two, but vital capacity was, and residual volume was increased in this group. So again, residual volume being a sensitive measure of prolonged abnormalities, the ratio of RV to TLC was also increased, as were some measures of obstruction, which we'll talk about next time. Soumya Swaminathan was a pulmonary fellow here in 1987-89. She looked at children who'd had meconium aspiration syndrome as neonates who were now age 8. Looked at 11 of these children versus 9 controls. Gestational age and birth weights were not different in this group. And again, total lung capacity not different, vital capacity not different, but residual volume was increased, and expiratory flow rates in this case were not different. So residual volume was the only thing that showed a difference. Rafika Hamuchi-Ursu, also a pulmonary fellow here at Children's Hospital Los Angeles, 1998 to 2001. And she studied 50 children who had been on ECMO for neonatal respiratory failure, compared them to 27 controls. Age was not different. Full term, reasonable birth weight. The indications for ECMO were shown here. Meconium aspiration was the most common sepsis and pneumonia, congenital heart disease, a few persistent pulmonary hypertension in the neonate, and respiratory distress syndrome. All cardiac lesions were completely corrected at the time Dr. Ursu's study was done. And she found again no change in total lung capacity, no change in valve capacity, but an increase in residual volume. Again, being a sensitive index. So in children with mild lung disease, the residual volume is often abnormal when other lung volumes and flows are normal. Hyperinflation is a sensitive test to detect early lung disease. Measuring FRC. Can't do this with a spirometer, right? We cannot measure residual volume, functional residual capacity, or total lung capacity by spirometry. So how do we measure them? And how do we line them up with spirometry to get our full complement of lung volumes and capacities? So basically, FRC, the most stable lung volume, can be measured by nitrogen washout, helium dilution, or body pressure plus osmography. Now, we could measure any volume using nitrogen washout, helium dilution, or the body box. So which one do we pick and why? So it turns out we pick FRC. And the reason is this is the most stable lung volume. Remember, it's determined physiologically. Therefore, FRC is used to match with spirometry, and this will permit us to calculate to lung capacity, FRC, and residual volume, which we could not measure with spirometry alone. So three techniques are used. All of these can measure any lung volume, but again, the volume measured is the air in the lung when the shutter is closed or when the patient is turned into a circuit. So let's talk about these in sequence. Nitrogen washout. If we ask somebody to breathe 100% oxygen, we're going to wash out the nitrogen from their lungs. All right. When this test began, their lung volume was 79% nitrogen. Okay. So we can now basically have someone breathe 100% oxygen, so they're breathing through a one-way valve. They breathe oxygen in, exhale, and this exhaled gas is collected. Okay. Ultimately, by the way, this is mixed expired nitrogen, not end-tidal nitrogen, which would be written this way. So mixed expired nitrogen. Well, basically what we're doing here is we're plotting percent nitrogen here, and as we continue to inspire oxygen, you can see that the percent of nitrogen falls. So we're washing nitrogen out of the lungs. And then at the end of the test, there's no nitrogen left in the lungs. So if we have collected all of the exhaled air, all of the nitrogen, okay, then we know that the FRC is the total volume of nitrogen, which is the minute ventilation or the ventilation, times the fraction of exhaled nitrogen divided by 0.79, because at the start of the test, the lungs were 0.79 proportion of total lung volume. All right, so this can be done and used to be done by collecting exhaled gas, as example here. And this really is what used to be done. You'd collect, have someone breathe oxygen in, collect exhaled gas. You'd have a certain volume, you'd have a certain percent, and you could calculate based on this formula what the FRC was. Computers now integrate fraction of exhaled nitrogen for each breath and calculate the sum. So there's no need to collect all the exhaled air anymore. And consequently, this is one of the more popular ways of measuring FRC. Now, it does measure only air that communicates with the mouth, or more correctly, it measures relatively well ventilated areas of lung. The standard is 7 minutes, so poor effort is usually associated with a leak around the mouth, and this will increase the nitrogen collected and artificially increase the measured FRC. Another technique is called helium dilution. This was the most popular way of measuring FRC prior to the computer era, because to measure nitrogen washout, you had to collect a huge amount of gas. So basically the idea is we have a spirometer that's filled with a certain concentration of nitrogen. When you start the test, obviously there's, helium. When you start the test, there is no helium in your lungs. So if we keep this as a sealed gas system, the volume of, 1 times concentration 1, this one, equals volume 2 times concentration 2, which would be the total volume. So we open up the system and we let helium equilibrate throughout the system. And then volume 1 times concentration 1 equals volume 2 times concentration 2. So volume 2, okay, equals volume 1 times the first concentration divided by the second. Now remember that volume 2 is the spirometer plus FRC, so you need to subtract the spirometer volume to get FRC. And so this would be the formula. Same thing shown here. So here we have a spirometer with helium. You now open the system up, and again, V1C1 equals V2C2. How do we know the volume of the spirometer? What was V1? Well, it turns out that we can do a helium dilution on the spirometer, right? And we simply do that by a certain amount of 100% helium, letting that equilibrate throughout the spirometer. Same thing, helium dilution, and this will give us the volume, and then we're ready to go with our test. The spirometer now is the measured volume of the spirometer tubing, etc., and it's used as V1 in the basic helium dilution equation, which is shown here. If you look at a helium dilution machine, you actually see that there are two bells. Helium dilution measures only air that communicates with the mouth. More correctly, it measures only well-ventilated areas of lung. All right. So the ATS standard is 7 minutes. Poor effort again is usually a leak around the mouth, which means that helium will leak out of the system. The concentration will be lower, and therefore the measured FRC will be artifactually high. So what is this extra spirometer? What's this extra bell? Well, the amount of gas in the system must remain constant. So if you're breathing from the system for 7 to 15 minutes, you remove oxygen and add CO2 to the circuit. You must add the needed oxygen back and remove the CO2. So you need to be sure that the circuit gas volume remains constant. So CO2 absorber removes CO2 and you add oxygen to keep the volume baseline constant. And so this extra bell is the oxygen reservoir. And again, now that we've kept the overall volume constant, this equation is valid and we can measure FRC. All right, finally measuring FRC with the body pressure plethysmography. This is the body box, and this uses Boyle's law. So Boyle's law says if we have a volume of gas that is isolated, and we change the volume, we also change the pressure. So if we decrease the volume, we increase the pressure, or pressure times volume equals a constant. So we've got some in the body box, and we close the shutter so that we've now basically isolated this volume of gas. All right, so we know what the pressure is in the gas initially. It's barometric pressure. All right, we ask somebody to pant, and we can measure the pressure change here at the mouth. And we can use Boyle's law again so that we can measure the volume change. Just backing up 1 second, okay? If we knew barometric pressure, we knew the change in pressure, and let's assume for a moment we know the change in volume. If the change in volume with this pant was relatively large with respect to the initial value, then this pressure change will be relatively large with respect to barometric pressure. If this volume change was small with respect to this initial volume, then the pressure change will be small compared to the initial barometric pressure. So I think you can see that there is a relationship there, and you ought to be able to figure out in some way how to actually calculate V, which is our FRC. So we do this by using Boyle's law again. We enclose somebody in a box which is sealed, and we can measure the box pressure, right, which we basically calibrate as volume. All right, so this basically is calibrated on a daily basis. The box is closed, and a 50 ml oscillating pump moves air in and out of the box, and that records a pressure change, and we calibrate that as 50 mLs of volume. So box pressure is actually calculated as volume. So now we can measure this delta V. So I just mentioned this, body box calibrated daily, box pressure is calibrated as change in volume, 50 ml oscillating pump in a sealed box, So box pressure swing equals the volume swing, and we can measure the delta V. So this is the body box, all right? And therefore we can measure those three things. This, just for fun, is what some of the original body boxes look like. Pretty small, um, not perhaps too comfortable, especially if you're claustrophobic. This is what a current body box looks like, and you can see it's much friendlier and not nearly as intimidating. This is an individual who is doing this maneuver. And what we have in the body box is a filter, which is standard, a pneumatic to measure flow, a mouth pressure device, and a shutter. Okay? So here's what we're going to do. We're going to close this shutter, right? And now we're going to say that inside the lungs, pressure times volume equals a constant, right? And if we differentiate this with respect to pressure, okay, the derivative of a product, well, first of a constant is zero, because a constant does not change. A derivative of a product is the first times the derivative of the second, plus the second times the derivative of the third, of the first, sorry. So these obviously cancel. So volume now equals minus P, this is atmospheric pressure, over this, right? The minus because these two change in opposite directions, but it's going to be a minus times a minus, which will cancel. For reasons I'll show you in a minute, we're going to flip this and make this pressure over dP dV. Now, you don't like calculus. All right, let's go through this by algebra. So P1 V1 equals P2 V2. So P2 equals P1 plus delta V, and V2 equals V1 plus delta V. So we can put that back in this equation, expand that out. These two PVs cancel. So now we have P1 delta V plus P1 delta P plus delta P delta V equals 0. Now this is a very small number. We're having someone pants, so a small times a small is even smaller. So we're going to just ignore that for the moment. So now we have V delta P equals minus P delta V. Again, we get the same equation that we did using calculus. So now, when the technician measures body box, so this individual is panting in the body box, and now we're going to plot mouth pressure against box pressure or volume, and you're going to get a slope. Okay, so the tangent of this angle from trigonometry is opposite over adjacent, or delta P over delta V. All right, and so what we're going to do then is put that becomes now in the denominator of the previous equation. So the volume equals minus atmospheric pressure over the tangent of this angle. Now, sometimes we get great oscillations like this, and it's easy to pick that tangent or that angle off. Sometimes we get curves like this. You want to ignore these tails. So it's again, this center part is what you're interested in. Sometimes, unfortunately, we get things like this. Kids often take too big a pant, and the honest truth is it's hard to know what the right answer there is, and probably you could not accurately determine FRC from this particular maneuver. The box was calibrated with empty, so we're going to need to correct for body volume. So now we've put a human in there, and that human takes up some of the original volume. When there's a change in volume within the box, now it's going to reflect a higher pressure because there's less overall gas in the box. So we have to correct for that. And we do this simply by saying that since the human body is mostly water, we assume a density of 1 kilogram per liter, and therefore we correct the volume by volume of the box minus body weight, which is assumed to be near body volume, over box volume. So that factor is used to correct the previous number that we get. The body box measures any air that participates in the volume oscillation. So this is both communicating and non-communicating air, or more correctly, both well-ventilated and poorly ventilated areas of lung. It may, this is controversial, may measure transverse colonic gas also, but this is estimated to be less than 160 mLs in adults and probably doesn't make a lot of difference one way or the other. We also have subjects hold their cheeks, and the reason is that if you do this panning maneuver and you're oscillating volume within your mouth, that will be picked up in the measurement. So you basically hold your cheeks to keep them from oscillating. Porphyrin is usually a leak around the mouth, which will decrease mouth pressure measurement, and this will result in an artificially increased FRC. Large panting also makes the FRC inaccurate. What if a child is scared? You can have the mother or another adult in the box with the child. Now, you obviously need to add her body weight in the correction, the weight correction, and she should breathe continuously. We do not want her to hold her breath. So long as she is continuously breathing in and out, this will measure the child's FRC, but not hers. Okay, so that's important. They keep breathing. You ask them not to hold their breath, but you can have another person in the box with the child if they're scared. So this is body box again, and the main difference here is that it measures both communicating and non-communicating air, any amount of air that's participating. So if we just kind of review here, nitrogen washout, helium dilution, body box. Communicating air is measured by all of them. Non-communicating is not measured by nitrogen washout or helium dilution. Okay. Well-ventilated areas, again, by everything. Poorly ventilated, not by nitrogen washout or helium dilution, but it will be measured by the box. If you had a pneumothorax, now we would not do pulmonary function testing on someone with an active pneumothorax, but if you had someone with a pneumothorax, that volume would be picked up by the body box because it's participating in that oscillation. It will not be picked up by helium dilution or nitrogen washout. If you had a thin-walled cyst in the lungs, but it was sealed, this would not be picked up by nitrogen washout or helium dilution, but it would be picked up by the body box because it participates in the oscillation. Decades ago, there used to be a treatment for tuberculosis called plombage. And literally what they used to do was put ping pong balls in somebody's chest to cause the lung to collapse, to rest it, right? That is a rigid walled cyst, and that would not be picked up by any of the techniques because a rigid wall cyst does not participate in the oscillation for body box. So measuring trapped gas. So a gas washout or dilution measures only communicating air or well-ventilated areas of lung. The body box measures both communicating and non-communicating air, or more correctly, well-ventilated and poorly ventilated areas. So the difference is gas trapping or poorly ventilated areas of lung. Now, I will tell you, when I first started at Children's Hospital Los Angeles, we used to do both. We would do a helium dilution and a body box. And I was going to look at the difference between the two as a measure of gas trapping. The problem is that for most young children, being able to keep their mouth sealed around the mouthpiece for helium dilution was difficult. And the helium dilution value was often greater than the body box value, meaning that they'd had an air leak. So that I finally gave up doing that simply because the times we could use the information was relatively infrequent. But in somebody who is well, who has good effort and ability, this is something potentially you could think about. So abnormal pulmonary function parameters are restrictive lung disease, decreased lung volumes, and obstructive lung disease. Total lung capacity is the measure of lung size. Restrictive lung disease is defined as a decreased total lung capacity. Vital capacity is not sufficient to diagnose restrictive disease. Hyperinflation is due to early airway closure and airway obstruction. Hyperinflation can also be due to inability to compress the chest wall in chest wall disorders and neuromuscular disease. RV is determined by outward chest wall recoil in normal children. An increased RV is hyperinflation, and RV, FRC, TGV cannot be measured by spirometry. TGV is thoracic gas volume. I meant total lung capacity there. Nitrogen washout measures only communicating air. Helium dilution measures only communicating air. Body plethysmography measures both communicating and non-communicating volumes of the FRC. Next time, we will continue to explore pulmonary function testing, and we will be talking about maximal expiratory flow rates, or the measures of obstructive disease. So thanks again to our producer director, Katie Lewinter, and thank you for joining me on this, the great adventure, pediatric pulmonary physiology.